Turns off what?
Yes.
Yeah, I just have to press the lock button. Yeah, it turns
Doesn't
off.
shut down the...
No, it runs behind, yeah.
Oh.
I just...
And shut down, and every like 10 minutes, it just comes off to show me that's recording. I just developed a jailbroken.
What's the advantage? I jailbroke my iPod actually.
Your what?
iPod Touch.
You jailbroke it?
Yeah, I jailbroke it.
Now you can download free apps.
I don't use many apps though. What kind of apps you use from the jailbroke?
Free.
I have everything on free over here on this Android.
Are you rooted? Is it rooted?
Is it what?
Rooted.
What is rooted?
It's like jailbreaking, but I'm
No, this is Android. No. It's not rooted or it's broken, you know?
You can root it with the same thing as jailbreaking.
No, it's not actually. I have enough applications what I need actually. I have full Micromatic, man, you know?
Yeah, I have them all, but the electric is like $300.
Oh. What the hell?
Welcome back. Alright, substance use disorders. First of all, before I get started, where's Alexander? Is Alexander here today? So, somebody was paying attention last week, because we went on Friday, we were going over the study, and we were looking at the risk difference on one of the tables. And I was talking about odds ratios, or relative risk. Now, Alexander raised his hand and said, and I made the claim that with odds ratios and relative risks, you exclude significance if it doesn't contain 1. And then Alexander raised his hand. He said, "Aren't you saying, don't you need 0?" And I said, "No, I need 1." And we went back and forth, and we didn't agree. Well, the reason we didn't agree is because the study is talking about relative risk difference, and I was talking about odds ratios and relative risk. I pretty much caused the confusion because I was just talking about odds ratios and relative risk because that's what I had in my mind. I didn't even look at that. Didn't read it as carefully as I should have. So the good news for me is somebody was actually paying attention, so I know that at least one person in the room was listening on Friday, so that's good news. But what I had said was correct. Odds ratios and relative risk, you exclude if the confidence interval doesn't contain 1. For relative risk difference, you exclude if it doesn't include 0. All right? You with me? Did you get my email, by the way? All right. So, substance use disorders. Going to get right into it. Not waste any time. So that's kind of a schematic of what substance use disorders does to people. It fragments their mind, it fragments families, it fragments everything. Any of you who know somebody with a substance use disorder knows how catastrophic it can be. So pretty much, the way that I've formatted all of my disorder-based slides is it follows a Napiro format. If you go to Napiro and you look at my slides, you're going to see a similar layout, and that's just so there's standardized language on the slides. It's just so I don't, you have so many different professors that'll come through here and they all have slightly different styles. This is one way at least to make it a little more standardized. So that's why pretty much in some of these sections you're not going to care about as much, although you need to, but I know you won't. Not everyone gets that excited about epidemiology, for example, but you have to know the sections that are in here, even though it's not all for medications. So epidemiology, these are three examples of the most commonly used substances in the United States. And this shouldn't be a surprise to anybody. Alcohol, prescription medications, and marijuana. Now the big surprise here is that over the last few years, prescription medications, the non-medical use, actually caught up to marijuana. It was always marijuana followed alcohol followed right by marijuana. But now, because there are so many fun psychopharmaceuticals, non-medical use has caught up to marijuana in some states over certain years. This changes. It's not an absolute statement. But in recent years, the non-medical use of prescription medications, I'm not going to keep saying that over and over, the non-medical use of prescription medications is what we call it, prescription drug abuse. There are many different ways to say it. I'm going to choose which one's the shortest, I guess, or I'll probably bounce around a little bit, but they're all interchangeable terms for the purposes of this course. Risk factors for drug use. Male, younger age, those with a family history, and those with psychopathology. Now, psychopathology can be anything from schizophrenia to a personality disorder, anxiety. Psychopathology is very broadly defined, but it is clearly a risk factor for substance use disorders, both ways. Now, I'm going to show you a little bit of raw data from one of the most well-known studies, just to kind of show you what a study like that might look like. So, the NESARC, the National Epidemiologic Survey on Alcohol and Related Conditions, is one of the gold standard epidemiologic studies in the United States. It's where you find information on drug use and mental conditions, prevalence rates, how well they correlate with each other, et cetera, et cetera. So in wave one, where I pulled this data, there were 43,000 interviews conducted. And that's a sample size of 43,000. That's ridiculous. Face-to-face interviews. So it's a pretty intensive trial, to say the least. But this is where you obtain statistics on who's doing what in the United States. One of the studies. There's also Bethesda, the MTF. There are a few of them, but this is one of the biggies. So let's get to some of the data. It's easy to say that if you have a substance use disorder, you're more likely to have a psychiatric disorder and vice versa, right? That's pretty easy to say, commonsensically. Studies like this give you the magnitude of how strong those relationships really are. That's what you look to these studies for. Yeah, common sense tells me that if you're snorting cocaine, you're more likely to be depressed. However, that said, what are the magnitude of these differences at the population level? All right? So what I did is I went to the NESARC and I looked at all the baseline rates of different disorders. And I picked some disorders where the prevalence rate was approaching 10%. So that means that approaching 10% of the population in this study had a mood disorder. So 10% of the entire sample had a mood disorder in the past year. All right? The same held for substance use disorders. Approximately 10% of the whole sample, so what is that, 4,300 people or whatever, had a substance use disorder in the past year. Right? So, that would mean, for example, 10 people in this room would have a mood disorder. And another 10, maybe some overlap. I'm going to argue there would be some overlap. But 10% of this room, 10 of you, would have a substance use disorder. All right, that's what that means. Now, if you start looking at subgroups, risk stratification type subsamples, you'll see that in both cases that approximately doubles. What that means is if I look at all of the respondents with the mood disorder, right? So I take that 10% that has a mood disorder, and then I look at the prevalence of those with a substance use disorder, it doubles to 20%. So what that means in epidemiologic language is that substance use disorders are overrepresented in mood disorders and vice versa. In both cases, it doubles. They're overrepresented. So that is a way to show the magnitude. That's an enormous effect. If you're saying that 10% of the general population, but if I take those with a certain disorder, those 4,300, that 20% of them have the other disorder. All right? Any clarifications needed on that? Bipolar, unipolar, yep. Manic, depressed, unipolar depression, things like that. Well, this is a substance use disorder. So we're going to get into the definitions of these, but personality disorders, remember, are Axis 2. And they have information on Axis 2, but I'm talking about Axis 1 psychiatric disorder here, in this line. But NESARC does collect information on Axis 2 disorders. That's it? That's the only question? You guys are straight on what that means? How to interpret that? You might get some stuff like that again? Maybe? All right. Again, no surprise that substance use disorders are a huge cause of death, illness, and disability. Right? You all know that. Somebody with a true substance use disorder is going to die younger, is going to have medical complications, et cetera, et cetera, et cetera. I'm going to show a little bit of data on suicidality, and then one of the areas that I've done some research in myself showing that substance use disorders is one of the biggest predictors of treatment non-adherence. Even if you remove other factors out of the way, as Kayla and Rachel can tell you, they helped me with the paper on this. If you get rid of all the other risk factors, disorganization, and you control for cognitive dysfunction, et cetera, et cetera, et cetera, they are still at greater risk for treatment non-adherence. Why? You can help me write a grant if you want to answer it. So, some suicidality data. Again, a study just to show we know it makes sense that people with substance use disorders are going to have an increased likelihood of being suicidal, or at least that would make sense to me. Maybe that's not intuitive to everyone, but I would think that if you just said, yeah, you have a group with substance use disorders and a group without substance use disorders, is there a difference in the rate of suicidality? I would say, yeah, but what is the magnitude of those differences? This is just an example study. I could have chosen many to say, okay, you have 107 patients in this study that have co-occurring MDD and alcohol dependence. Then you have close to 500 alcoholics who aren't depressed. Then you have a third group who would kind of be like the control group that is non-alcoholic depressives. So that would be basically a sample of close to 6,000 people who are depressed, right? Again, that's kind of the control group because your primary outcome you're looking at is suicidality. Who would you expect to be the most likely to be suicidal? Those with depression. No. So when I say MDD in this study, or in any slide, MDD is major depressive disorder. COD is co-occurring disorder. You guys remind me. I think next year we'll have a glossary. Like when when you write a book chapter, it would have a glossary at the beginning. I'll probably start putting one of those in because I just take them for granted and I throw them around and forget. Just so you know, from an academic, from a learning point, whenever you write anything, and slides are a little bit different because you can verbalize your slides. When you write anything, you're supposed to spell something out the first time it appears. Generally, the reason I don't do that in slides is because you're trying to save space, you're trying to talk, and you're trying to say a lot of information in how many minutes. But generally, you want to write it out the first time it appears. So that's major depressive disorder. The other abbreviation on there is alcohol, right? EPOH, alcohol. Anything else on there? COD, co-occurring disorders. Yeah, okay. So the outcome of this study was that the depressed alcoholics, the 107 depressed alcoholics, reported 59% higher rates of suicidality than the people that were depressed without co-occurring alcohol dependence. All right, so that's 59% higher. Again, these are huge effects. I'm cherry-picking studies that show these huge effects, but that's what you want to do when you're trying to make a point, right? But again, I could have picked many, many studies that would have shown the same thing. That's why I can cherry-pick one, because I know I can locate a bunch more that say the same thing. Again, just so you have magnitude of effects. Why? Anybody wondering why I'm talking about substance use disorders first? That's because every disorder that we talk about from here on out has a very high co-occurring rate with substance use disorders. Everything. Some people put it last for the same reason. We talk about other independent disorders, and then they talk about it. The thing is, I'm a firm believer in asking questions, and Crystal can tell you. She did very well in my section, so she'd be a good person to ask, actually. That I don't believe in asking questions of the true your P2s, and I got to make it as clean cut as possible and say they only have one disorder, because that you know how rare that is. If somebody comes in and only have one thing going on. So the reason I give you substance use disorders first is from here on out, you're going to have to be able to answer a question about somebody who's depressed with or without a substance use disorder, because it's different. You would treat anxiety different. You might treat depression different. Schizophrenia, you might treat different. Everything from this point onward, there's different answers based on whether or not there's substance use disorders involved. Is that fair, Crystal? So, you're going to want to pay attention to that. All right. Etiology, pathophysiology. Yes. What? GAD. That is generalized anxiety disorder. OCD is obsessive compulsive disorder. Panic disorders there. Major depression, bipolar disorder, schizophrenia, and schizoaffective. And those are the three kind of major classifications. You know, anxiety disorder realm, you have your psychotic disorder realm, and you have your mood disorder realm. Etiology. So everything that I say from this point forward in terms of etiology, pathophysiology, is mostly driven on well-documented theory, well-supported theory. But it's theory, it's the brain, right? We're getting closer because we can get imaging studies, proteomics. Did anybody go to Dan Brizeau's? Was anybody here in Dan Brizeau's genomics course? You know, we're starting to get to the point where we can do genomics, proteomics, et cetera, et cetera. So some of these theories have more justification to them, but they're still just well-accepted, well-data-driven theories at this point. So yes, could you go out and find another theory that I don't talk about? Maybe. If you do, that's great. I always like to learn, but this isn't the end-all, be-all. But for the purposes of this course, these are concepts that you need to know because they're kind of accepted no matter which theory you believe in. I don't pick any kind of outlying theories and make you learn them. We're kind of talking about the well-accepted good stuff here. So, the first pathway that we're going to get very specific on, which I alluded to the first day, is the mesocortical limbic dopamine pathway, otherwise known as the reward pathway. The reward pathway exists in your brain to drive you towards things that are going to keep you alive: sex, water, and food, right? Being three of the big ones. That's how we procreate, right? You need food, water, and sex to procreate. That's what the reward pathway does. When you take substances, you're basically, you know, the common phrase is you're hijacking that pathway for your own devices. And then you could be combining it with sex or food, but you get the point. It's all driven towards increasing reward in that pathway. So I can guarantee, unequivocally guarantee you will see this pathway on some form of future assessment of some kind. But we're going to talk more about it. So every drug of abuse known to man, I told you day one, in some way, shape, or form increases dopamine in that pathway. A lot of other things happen as well, but that's the one thing that everybody agrees on. Not everybody agrees on what that means, but everybody agrees that every substance does that in some way. Right? You can find some smatterings of theory, like of data, that say that maybe opioids can do it. Just the opioid mechanisms, because any long distance runners in here, you know, runner's high. Who's ever heard of runner's high? Right? Part of the runner's high is believed to be driven by, you know, endogenous endorphins, maybe dopamine independent, but again, the well-accepted standard at this point in time is that you increase dopamine in that pathway in some way, shape, or form. We already talked about it supports life-sustaining behaviors. So remember, dopamine pathway, everything's going to build off of that. Homeostasis, building off of that, is the fact that your body wants to stay. It has its own homeostatic set point, right? Is homeostasis, is this language that's new to you, or is this something you're familiar with? Familiar? Right? So when you start doing things to hijack your dopaminergic pathway, your body's going to try to maintain homeostasis. So we're going to keep coming back to that because that presents problems, and I'm going to tease that apart a little bit. Now, again, I said that you need something from outside of the body to procreate. The 3 examples that I gave you, the dopamine pathway is there to help you go seek those things out, right? So again, we're going to build on the dopamine pathway, and we're going to build on homeostasis. Those 2 concepts are kind of the foundation. Here's another pictorial. I've been using this one for years, and it basically gives examples of where drugs may act to increase dopamine. Like, for example, it's saying, well, maybe opioids and alcohol can increase cell firing in the VTA, or maybe they directly increase dopamine in the nucleus accumbens. But in either case, whether you are increasing cell firing or whether you're increasing dopamine at the synapse by inhibiting the reuptake pump, for example, however you got there, the net result is increased dopamine in that area, right? So that's all this diagram is meant to say, is that yes, it may happen on either end of the pathway, but it does happen. So, if we all have the same reward pathway, why do things go sideways for some people and not for others? So, first of all, there's the abuse liability of drugs. Right? If you smoke, and we're going to get into kinetics a little bit. Kinetics play a major role, as I say there. If you smoke a drug, you get it to the brain very quickly. The abuse potential skyrockets. So, if you have 2 people and one person's drinking, and this is an oversimplification, but if you have one person drinking, consuming alcohol orally, and the person right next to them is smoking heroin, the subjective high is likely going to be higher for the person smoking heroin because of pharmacokinetics, right? You're getting the drug to the brain very quickly. Well, that may make that person more vulnerable to using it again than maybe the person consuming oral alcohol. And that's an oversimplification just to say how some of these things tease apart. But that's why smoked drugs, nicotine and opioids, and what else? Methamphetamine. Those drugs become, you see those people, right? Everyone, you've heard of meth mouth, you've heard of people, has anybody ever seen Requiem for a Dream? The things that people do to keep using drugs. Those smoked drugs are very addictive. So that's part of the story. The other part of the story is that we all have unique vulnerabilities. Go talk to Dan Rizzo, he'll tell you, there are different responses that we're inherently going to have. Example, reward efficiency theory. If you are somebody who has lower dopaminergic tone to start with, you have lack of dopamine in your brain and your central nervous system, maybe you are less likely to experience natural rewards. Maybe. And maybe you're more vulnerable to the hijacking effects of taking exogenous substances. And that's, again, just one of many theories. But what that's getting at is the same concept that some people are likely, whatever it is, are likely to be more vulnerable to using a substance. Another example is alcohol dependence in Asian populations, certain Asian populations, is lower because of, has anyone ever heard of the Asian flush? Right? Because they don't break out, certain subpopulations of Asians do not break alcohol down as efficiently. Therefore, acetaldehyde builds up. And we're going to talk about this when we get to disulfiram in the next lecture. But acetaldehyde builds up, one of the metabolites in the process of breaking down alcohol, and it causes a flush-like reaction and nausea and so on. Do you think those folks are likely to go on and continue drinking to the point of alcohol dependence? No. So they're actually protected in a way from alcohol dependence at the population level. Now, I've personally known, I have friends that, that get the flush and they kind of come up with ways to continue to socialize in the United States, and drive through that. But that being said, that person is still much less likely to go on and develop true alcohol dependence because they just can't tolerate it the same. It's just not that fun, right? It's not that enjoyable. So there are different factors that play into this. There's drug-specific effects, there's human effects. All right? Now, this is a concept that caused people a lot of confusion last year. There is, when I talk about kinetics, there's positive reinforcement and there's negative reinforcement that play into this. When I give you the example that the quicker you get the drug to the brain, the more pleasurable that drug is likely to be. That's an example of positive reinforcement. Does anybody remember opera conditioning from psychology? Is that a question, or you remember opera conditioning?
No, I remember.
What?
Yeah, I remember.
Anybody else? Opera conditioning, positive reinforcement. It's something that's more, it's more likely to make that behavior happen again, right? It's like the classic, there you go, yeah, ringing the bell. There you go, the salivation in the dog, right? You associate the bell. Wait, I was thinking actually a drug use cue, like the ice cubes in the glass, or, the cigarette. That's why some people, it's more behavioral. They use like inhaler. Anyway, we'll get to that. Positive reinforcement. It's more likely to make that behavior happen again by adding the behavior, right? So if I drink something and I like it, that's positive reinforcement. It's more likely to make me do it again. Negative reinforcement is when you take something away, you're more likely for that behavior to happen again. In this case, a classic example is cocaine, where you get the subjective high, you get the positive reinforcement, and you take it away so fast because you metabolize cocaine so quickly, you've taken it away, and by taking it away of the body, by your body taking it away, you go from feeling euphoric to not euphoric very quickly. So by taking it away, you're more likely to make the person do it again because they're seeking again the original reward. Do you see the difference? I'll give you a slide. Another one of my favorite slides. Nora Volkow is the director of NIDA. She's a big deal. And she's been doing imaging studies on drug use for years. And this is a classic study that she did where you look at the lines. There's two different lines going on here. You have I guess that's a purple line, and you have the blue lines, which are the subjective, how high the person was, right? And on the left you have cocaine, and on the right you have methylphenidate. What you found is if you inject methylphenidate and cocaine and get it to the brain as quickly, then the high produced by either drug is equal, right? And I don't know if you know this, but methylphenidate and cocaine have an identical mechanism of action, identical. Which we'll get to in the stimulus a little bit more. But if you inject these dopamine reuptake blockers directly and get them to the brain quickly, the subjective high is equal. The big difference is that you clear that cocaine on the left very quickly, and you clear methylphenidate more slowly. So what is reduced? What kind of reinforcement is reduced? Yeah, say it loud if I can hear you.
Positive?
Negative. Negative reinforcement is increased with cocaine relative to methylphenidate because your drug cleared the body so quickly that it's seeking that pleasure again, whereas cocaine, or with methylphenidate, it's still occupying receptors. So your body is not seeking that high as quickly because the drug tapers off slowly. So this is definitely a good time for questions because this caused a lot of problems last year. Don't be shy. Ask questions if you have it, because I know for an absolute fact that not everybody in this room understands this concretely. I know it. Yes? It's because how long the drug is available at that receptor. With cocaine, the drug is not available at the receptor what do I have here on the bottom on the x-axis? By 60 minutes, it's already down to 20% of peak. If you look at 60 minutes on methylphenidate, it's still 80% of peak. So methylphenidate, you have drug at receptor for much longer because your body has not cleared it as quickly as it did for cocaine, which by 60 minutes has plummeted to 20%. So you have many more receptors waiting for more because you just had that peak in drug and that peak in subjective response, and you took it away really fast. Right? And you notice
it's 100%.
the high is still the same. You notice that you were just here, now you're here really quickly. Remember homeostasis. Your body doesn't like going anywhere. Right? Homeostasis, your body has a certain point of it, which it operates, and that's where it tries to stay.
Not feeling it. Right.
The subjective high
Yeah, she's.
It's a good question. The high's dropping, but in methylphenidate, you still have receptor occupancy, right? So you still have things going on. For example, you still may have elevated heart rate. You still.
Okay.
So when you think about drug use, on both, you ever heard of delta, the change from here to there? You can think about delta more than you have to think about absolute levels. So delta is, it's not the peak drug that you get to the brain, it's how quickly you get to the brain. Just like in terms of your body thinking it wants more, right? You still have to think about delta down, which is the change down, how quickly it's gone. So your body, even though the high is gone as quick, if the methylphenidate is still activating those dopamine receptors, and it's not identical. Your question is a very valid question. It's not identical. The high with cocaine is going to be up, and then it's going to be down quickly, right? I mean, I think we'd all agree on that. Methylphenidate, it stretches out a little bit, but by having, it's impossible for me to say, is it second messenger systems? What is it that your body recognizes about methylphenidate still occupying those receptors that it still doesn't think it needs more, right? Because remember, homeostasis. Think about homeostasis. Take the subjective high out for a second, and think about if your body is trying to maintain a certain status, do you think a quick change or a slow change is going to be harder for your body to deal with? What? A quick change, right? A quick change. I have stuff on that receptor, and then I take it away. Because remember, as soon as drugs occupy that receptor, you get downstream changes. And we're going to talk about that when we get to serotonin reuptake inhibitors, for example. That once you put a drug on board and you start blocking receptors, it's the changes that happen after that really matter. So in this case, you want to think about quick changes versus slow changes because of that homeostasis that I referred to in the previous slide. You have to consider your body is trying to maintain homeostasis, and it's going to be much harder for it to deal with, yes, you fully loaded my receptors and took it away, versus you fully loaded my receptors and then they're just going to self-titrate. I know, it's not an easy one, but I think you can simplify it to, if you keep homeostasis in mind, it'll help you get past this subjective high finding and just consider that the body, a self-titration is always going to be better. Think about benzodiazepine. If you're going to taper somebody off of benzodiazepine, tapering them off a long-acting benzo allows the changes. And this exact question, let me explain alcohol. Let me explain alcohol in a minute. We'll talk about why you get withdrawal. And it may help answer this question about like glutamate and GABA. So let's revisit this in a couple minutes. It might at least help some more. Yeah?
So are you saying because of the quick changes that you have more of a
I'm saying that cocaine would have more of an addictive liability, even if you get them to the brain at the same rate. So there's two things going on here. There's two separate things. There's the positive reinforcement and there's the negative, right? Two entirely separate issues. Which one has greater positive reinforcement according to this chart? What?
the same.
Yeah, say it loud if I can hear you. They're the same, right? Positive reinforcement is identical in giving the drugs identically because you're getting the change of drug to the brain is equal, right? You're occupying receptors very fast in both cases. Now, where they separate is on the other side of the curve, where the receptor occupancy is gone quicker. That's where you get problems because your body doesn't adapt that quickly, or it's trying to adapt that quickly, and it doesn't like those quick of changes of that magnitude. So if you're completely maximizing receptor, and what is it? It's close to 100% here, or peak. Well, you can. I want to say that peak. That's not the same as saying maximum receptor occupancy. Trying to think. I don't know how to say it other than because of the high. I can see why you're confused with the high. You have to think. It's funny. No one asked that last year because no one even thought about this. But I know it still caused a lot of confusion. That's why I'm concerned about getting this right. Because last year it didn't go well. How could I say it in a different way?
How long is the occupied at the receptor? The longer it's at the receptor, the less instance
Well, when you have drug at the receptor, it's still doing something. I guess what I'm trying, where I'm having trouble making the leap to explain to you guys is, if you have a receptor occupied, that doesn't necessarily mean that it's not a direct correlation between this receptor is occupied and subjective high. So first we have to disconnect those two, first of all. Because the subjective high is really more about the pleasurable effects. Okay, I think I can make this clear. The subjective high is more about how well you feel taking the drug. All right? That's what I want you to focus mostly about the subjective high. Right? You take a drug because you want to feel the pleasurable effects. In a minute, I'm going to tell you that eventually you take drug more because you want it than you like it. Okay? So when you think about positive reinforcement and drug use, think about how well it makes you feel. Initially. And eventually, I got this. I think I got this. Eventually, I'm going to tell you that it's not even the subjective high that matters. So I'm trying to take importance off that high for long-term dependency. Negative reinforcement becomes very important in long-term dependency, but it's no longer about acute liking of drugs. It's about wanting it. Why? Because the receptor changes. However, if I have drugs still sitting at the receptor, right, you're not getting the change back, because your body is going to push against drug. All right, your body is going to push against that drug being there. For example, if I give a stimulant, your body will kick out inhibitory neurotransmitters. All right, that's why somebody in stimulant withdrawal, one of the most common symptoms is depression, right? Because you have CNS depression, and GABA doesn't directly lead to depression. That's not what I'm saying. I'm saying you're the high, your dopamine's high, you take all that dopamine away, because when you get a huge burst of dopamine, it's gone. So all your feel-good transmitters are now gone. And on top of that, your body has dumped out inhibitory neurotransmitters because it wants to keep homeostasis, right? So now you're in a spot of CNS depression. Again, for two reasons. The mood part of it is probably lack of dopamine, but you also have the GABA-suppressing stimulant activity, correct? When you have methylphenidate still holding on, right, you don't, when you take the drug away quickly, you have all these changes that are downstream, that receptor is now open again, right? Whereas when the drug is still there, it's holding on and you're not getting as many changes because there's drugs still in the receptor. So try it, remember, when you have a receptor occupied, it does what it's going to do, right? The receptor is open. There's no changes downstream. You have your initial change, and then it occupies the receptor, right? You take that drug back out of the receptor, now the receptor is open again for activity, and you get changes. with me? I don't know if I'm making this leap for you or not.
So does the methylphenidate have a longer duration of action? Is that
Yes.
kind of what you're saying?
Yes. It does, but
So you're not necessarily feeling the high, but you're still, the drug still has an effect in your brain. And therefore you are less likely to crave it immediately.
you're less likely to crave it because you're not getting that delta change down in receptor occupancy. Even though you may not be subjectively saying, I don't have the high anymore, I'm going the other way, I'm going away from the high, your brain doesn't crave the drug as much because there's still drug occupying the receptors. I feel like there's a piece here missing that I'm not getting across to you guys. But,
whereas with the cocaine use, the body's trying to go back to homeostasis, but it's not fighting against anything anymore, so it goes well below that.
well, that's part of the story. That's part of the story. Is your body's fighting, and to get back to homeostasis, you've taken the drug away, and you clearly overshoot. I'm going to show you a slide here where we talk about that in a minute, right? Where you overshoot it the other way.
And
But
that's
if you
the
still
difference.
have drug, think of it this way. All right, here, think of it this way. This is the leap I'm looking for. Trust me, I've been spending time on this because last year this was a big problem for everybody. When you give buprenorphine, which we're going to get to next time, for opiate dependence, who's dispensed buprenorphine? When you dispense buprenorphine, you're expecting that not every time that person takes buprenorphine that they're going to have a subjective high, right? In fact, depending on their baseline opiate status, which we'll get to, it can also cause withdrawal, right? It's an opiate system stabilizer. So if you have excess opiates on board to begin with, you can actually antagonize opiate effects and cause withdrawal. If you're deficient in any kind of opiate on board, it can actually be an agonist and maybe cause some subjective high. But in general, when you give buprenorphine, you're hitting those receptors, but you're not necessarily giving a subjective response. You're tricking your body by occupying those receptors. Your body doesn't crave it. It doesn't need it because the opiate receptors are doing something. You're not sitting there thinking, oh, I got a subjective high off the buprenorphine. But your body is tricked into not craving it because you are activating the opiate receptor. Does that help? That's the same concept here. That's like people have been studying methylphenidate for stimulant addiction for years because of this very reason that it occupies the receptors. And if you take it orally, you don't get the same high that you would from injecting a drug. So by taking methylphenidate orally, you benefit from the receptor occupancy without getting this huge subjective high. And I think that's about as close as I'm going to get to going back to the basic pharmacology and what goes downstream and so on and so forth. We're basically doing agonist treatment on the latter half of this and tricking your body into thinking there's drug on board. Because there is drug on board, you're not tricking it. Without having the subjective high that goes along with it. Oops, I know this is going to be ugly down the road.
To complete yourself, tie back to reinforcement, so you're decreasing positive reinforcement.
With the methylphenidate, yeah.
So finish it off. I feel like that's what you're doing. And negative.
Can't say anything new for like a long time.
Methylphenidate, when you give agonist treatment in general, when you occupy the receptors, whether or not you have the subjective high, and you occupy the receptors, you're decreasing the negative reinforcement because you're tricking your body. You're not tricking it again because you are occupying the receptors. You're tricking your mind subjectively because you may not feel the high, but your receptors are occupied and the brain does not crave the drug as much. By not craving it as much, you don't fall prey to negative reinforcement. Because I can tell you right now, if you did cocaine and it was gone quickly and those receptors are wide open, you went from huge receptor occupancy to none. Your body craves, again, there's so many things going on, and one of them is homeostatic drive. You're going to be craving drug again, right? You're going to be craving it again. You have no receptor occupancy. That's negative reinforcement because you took the drug away and now you want it again. I guess it's hard to ask you guys to take faith in the conscious versus unconscious. You don't have to be consciously aware of how, I guess that's what I'm going to have to be comfortable with the fact that you don't have to be subjectively aware that your body still has drug on board and that it's preventing you from actually craving it again. I guess that's where I'm going to have to be comfortable with it, because there's really no way to say for sure this is why you're not craving. But I can tell you that's the whole premise of agonist treatment. Occupying receptors so your body doesn't crave it. All right? Oof. I don't feel great about that, but I think we have to move on. I know that's going to come up again. So, I will think of a black and white I will find a black and white way to explain that before you are in any way, shape, or form assessed on it. So if you're using a drug a lot, again, I want you to really remember this homeostasis where you use a drug and your body pushes back. The classic example is alcohol, where if I take a GABAergic drug, all right, my body is going to push back with excitatory neurotransmission. So if I take GABA, body pushes back with glutamate, and you have the opposing sides, correct? So here I am. I drink a little bit, the blue line, I feel that subjective positive reward from drinking. Some of that is mediated by the fact that GABA interneurons inhibitory. I don't want to confuse you with all of that, but the end result being dopamine increase. By increasing GABA in the central nervous system, you ultimately release dopamine. If you want to know, I don't think it's a good idea to go there. They're GABA interneurons, and you inhibit the inhibitory receptors, therefore allowing cells to fire. I don't think you want to go there. Take my word for it. Right? So you increase GABA, your body comes back with glutamate. Then the alcohol's gone, and now you're in a state of excessive glutamate. Right? Because the CNS suppressant's now gone. What does that excessive glutamate lead to? Anxiety, seizure-like activity, dysphoria, things we're going to talk about in a minute. Now, you don't feel that great after acute drug use, right? There's always a period after acute drug use where you dip, and it may be imperceptible, but where you dip a little bit below where you were at baseline. Most often this would be represented by, for most people, not even being hungover, but waking up and not, you feel a little bit sluggish and all that. You don't feel, you have the high the night before. And when I say high, I'm just talking about pleasurable effect. Like it can be drinking in moderation. It doesn't have to be high in terms of the way you might think of it. But you have a subjective high, and there's always going to be a little bit of a trough afterwards. Now, if that's it, if you went to a wedding and you had this increase in pleasurable effects followed by a rebound effect, you felt, someday you felt a little bit lethargy, whatever, then it's done. Where people get themselves in trouble is the frequent, if I don't give myself time to come back to the homeostasis, and I'm pushing back with glutamate, and I put alcohol on board, and I'm pushing back with glutamate, and I put alcohol, GABA on board, and I keep doing this over and over and over again, well, eventually, right, you build up tolerance, for example. All these other metabolic issues are going on at the same time. And what you end up with is somebody who's built up some tolerance, and their GABA and their glutamate are opposing. Now you strip the alcohol away for this reason or whatever reason, and then you have acute drug withdrawal. All right? Acute drug withdrawal. Because they were living at a point where they're not back to their true homeostasis. Because you know the 5 half-life rules for a drug? I'm going to make a leap here. 5 half-lives where eventually you reach steady state. If you keep putting a CNS depressant in and getting these peaks and troughs, you eventually have a lower, and you never give yourself rebound to get back to homeostasis, what you end up is at a lower set point. It's kind of like the 5 half-life, it's not 5 half-lives, but it's like that going in reverse. You reach a new steady state below your original homeostasis. That's why when you take the drug away, you have acute drug withdrawal, and that's problematic. But then for months after that, the person is in a state of withdrawal that we'll talk about in a second, with things like anxiety, lethargy, anhedonia, agitation, et cetera, because they're digging themselves out of this lower threshold, this new set point. Right? Go back for just a second. The wanting liking, this is where I was trying to tie this into your question before about subjective high. There's this theory that the wanting liking, when you first take this drug, pointer here. You see this? When you first take the drug, this feels good, right? It feels good. It gives you a pleasurable sensation, and then you have the natural drop. Your body clears the drug. You may have a little dip, and then you're back to normal if you give yourself enough time. You keep doing this enough, and you end up at this new steady state that I was telling you about. You are now in a state of reward deficiency. And when you take drug, it's only getting you back up to where you may have been at baseline before you started this whole cycle. So now, with an altered set point, you no longer like the drug, but you compulsively want the drug. Because you're trying to, right, you want the drug, because if you don't have it, you're like I said, you're kind of in reward deficiency is where you would be the closest theory of addiction. So you've kind of put yourself in a bad spot. And that's why after the acute withdrawal is over, that's why the extended withdrawal goes on for months, because you have to wait for all of this to normalize and get back where you started, the homeostasis. The bad news is, for some people, if they were already reward deficient, they're going to climb back to homeostasis, which is already deficient. But that's why you need agonist treatment, and we'll talk about that in a minute. But that's why agonist treatments and treating co-occurring disorders and all that becomes so much important, much more important. So, let's talk about that. Let's go. We gotta move on to the clinical presentation. So, DSM-4, every disorder, you have to know DSM-4. I start every lecture pretty much at some point at the beginning of each module talking about DSM-4. Substance abuse and substance dependence are these are two distinct entities that we'll talk about, that I'll define further. Maladaptive and reoccurrent is substance abuse. This is, people do drink, drinking's the best example for, it's the prototype for substance use disorder. So I generally refer to drinking, but it could be stimulants, it could be opioids. But when I say drinking, again, that's because that is the prototypical disorder to define all substance use disorders. So it's maladaptive, it's reoccurrent, and it's associated with adverse consequences. Now, true dependence, becomes very compulsive. And it's not just recurrent use with side effects. It's compulsive use despite the fact that there's negative stuff going on. We'll get into the negative stuff as we go through the lecture. But there's a big difference. Recurrent use with some side effects versus compulsive use despite a lot of side effects. Now, abuse, this whole recurrent abuse, believe it or not, you only have to fulfill one of these symptoms in a 12-month period in order to meet the diagnostics for abuse of a substance. Now remember, it also has to cause disruption in your functioning. It also has to cause significant distress. Remember, there are other criteria that go along with all of these diagnoses. Significant functional impairment, significant distress. I mean, if you went out, and it's recurrent, can't say that enough. If you went out, you were in a relationship, and you had periodic fights with your spouse because of your drinking. But say it didn't impair any functioning, didn't cause you any legal problems, It didn't put you in a hazardous situation. It wasn't like you guys were driving. Just say you had a few altercations over the course of the year with somebody else. But it didn't cause you distress. And it didn't cause any interpersonal problems because you guys got over it. Would that be necessarily a disorder? Probably not. Where it becomes a disorder is where you're fighting with your spouse and you get tired of arguing and you get in the car and you go to the bar when you already have been drinking and then now you're behind the wheel of a car and this is reoccurring, right? You have to think common sense. It's not just you met one of these or you didn't. It's you met one of these, but you have to think about the bigger context. All right? Dependence, you have to have 3 or more of these happen in the same 12-month period. And again, it's compulsive use. So now you're giving up other behaviors. This is where somebody comes in and says, my spouse, we're not even fighting anymore because my spouse doesn't even come to the soccer games anymore. I don't even see him because he's always gone. He's always at the bar. We don't run together anymore. We don't do this together. That's where they start giving up other things. It becomes very compulsive. It causes psychological, psychiatric, physical, psychological. It causes all kinds of problems, and yet the person still continues to do it. So you got to think there's a huge difference between abuse and dependence. All right? And you have to look into the case and think, is he trying to describe someone who's compulsively using this at the expense of other life-sustaining behaviors? Or is he talking about somebody who's abusing a substance? Or is he talking about somebody who's misusing this substance but probably wouldn't need a diagnostic, a disorder criteria? So you kind of, like I said, you have to be very careful in interpreting the case. I talked about this a little bit in my abysmal attempt to explain negative reinforcement, where alcohol, it's GABAergic, and your body's going to compensate for homeostasis with excitatory neurotransmitter, namely glutamate. I don't want to spend too much on the kinetics just because we lost some time there. But one of the most important things is alcohol is one of the few drugs in all of psychopharm that follows zero-order kinetics. Anybody remember what zero-order kinetics is?
It's constant.
Metabolized at a constant rate, period. Right? So, if you can metabolize 20 grams of alcohol per hour, for example, no matter what, that's what you metabolize. That's why it becomes very predictable. That's why you can make up BAC charts. And that's why the police can tell you when you're arrested how quickly you can leave. Because they can look at you and look at your body weight and your gender and say, okay, men and women, the average I think is something like 18 to 20 grams per hour. I think that's the average for a population, but then you have to, like I said, look at gender and males is slightly different because of body fat percentage. And they can say, this is the population average for how quickly, because we know it's 18 to 20 grams per hour. Right down the way. It's not based on proportionality of what's left, like pretty much all of the other psychopharm medications, or drugs and medications and everything. So that's the one point that I'll mention there. Now, everything I talk about from an alcohol withdrawal standpoint goes back to the point that you should be thinking that the person's in a state of hyperexcitability once the alcohol's gone. You removed GABA, and now you're in a state of hyperexcitability. When you're in a state of hyperexcitability, you should be thinking about things like sympathetic overdrive, such as tachycardia, sweating, but you should also be thinking about dangerous problems like seizure activity. In fact, the seizure activity that's associated with alcohol withdrawal makes this a medical emergency. This is probably no surprise to you, but you can die from alcohol withdrawal, right? Seizure-like activity, aspirating. You have a seizure. A classic story is somebody has a seizure, or they vomit, and they throw up on their vomit while they're seizing. I mean, you've heard the classic stories. I mean, musicians who, you've probably heard the anecdotes. from a therapeutic standpoint, what you need to know is you have to treat alcohol withdrawal because it's considered a medical emergency from the dangers of death that ultimately are going to be from seizure activity, respiratory depression, aspiration of vomitus, those kinds of things, right? It's imperative. This is a pictorial that kind of, this is the same information as this, but in a different format. Yeah, they're pretty much identical, so I'm not going to spend too much time in them. Like I said, I've lost a little bit of time, so I'm trying to get some time back. Wernicke-Korsakoff, you're going to hear me talk about a lot. It's two elements of the same syndrome. Wernicke encephalopathy is kind of the earlier part that's more treatable, more preventable, and then there's the Korsakoff part of it that comes on a little bit later and is not quite as treatable. The Wernicke encephalopathy is driven by, they're both driven by thiamine deficiency, but the good news about the Wernicke encephalopathy, you can actually address it with thiamine treatment, which we'll get to once we get to the treatment side of things. The triad, the classical triad of Wernicke encephalopathy is mental status changes, ocular symptoms, and ataxia. Now, I used to go over this a little bit more at the beginning with cranial nerves. Part of the reason you go over cranial nerves is when you're doing the neuropsychiatric assessment, if they're an alcoholic, they could have some cranial nerve toxicity, that's the origin of the ocular symptoms. Nystagmus, anyone heard of nystagmus? Nystagmus is where the eyes may float some, and you can tell that the muscular control of the eyes is not correct. Part of that would be driven by neuronal toxicity of cranial nerves that control the extraocular muscles because of thiamine deficiency. All right? Same thing with the ataxia, neuronal toxicity in areas of the brain that control coordination, cerebellum, striatum. But it all goes back to neuronal toxicity due to lack of thiamine. This thiamine is a cofactor for glucose transport into the cells, and glucose is the primary energy source for the CNS. So if you can't use your primary energy source, there are problems. All right? So think thiamine. This is the logic progression here. Lack of thiamine, cells in the CNS cannot use glucose, neuronal toxicity leads to mental status changes, ocular symptoms, namely nystagmus, and ataxia, which is walking with an abnormal gait because their neuromuscular control is incorrect. When you get to Korsakoff psychosis, that's also the downstream, further worst-case scenario where you start having memory and learning deficits, and what really is the primary symptom that comes out of this is confabulation. Has anyone ever heard of the term confabulation? It's where patients start to feed in the story, I was going down. They start to fill in gaps in their memory with, basically what, it's lies, but they don't know, they're not necessarily trying to be malicious and lie to you, but they're filling in their learning deficits. You start hearing stories that don't make sense. When you see it, it's pretty hard to miss. But that may not be reversible. They're both initially caused by thiamine deficiency, but you can actually do something about the Wernicke. But we're going to, like I said, save that for treatment. Yep?
I'm sorry, what's the term again?
Wernicke-Korsakoff?
No,
Confabulation.
Confabulation.
Yeah. Confabulation. I had a roommate in college who did it all the time, and he wasn't even a drinker. He just made stuff up. But this is gonna be one of those easy way to get points or easy way to lose points for you when we get to the treatment side of things, when it comes to the assessment side, because I told you that alcohol dependence or alcohol withdrawal is a medical emergency. I'm also telling you now that thiamine is a cheap and safe way to prevent a lot of cognitive dysfunction. If you don't give thiamine to patients that are in acute alcohol withdrawal, you might, it's
This is 14.
the incorrect decision. We'll leave it at that for now, but we're going to give the treatment on part 2 of this. But thiamine is a water-soluble, safe vitamin that you should be giving anybody who you think would be at risk for Wernicke encephalopathy. And who's at risk for Wernicke encephalopathy? Who's at risk? What? All alcoholics. When you're an alcoholic and you're drinking, you're not absorbing B vitamins. You have an inadequate intake and you have an inadequate absorption in the GI tract. So anybody you ever treat with alcohol withdrawal, you should be treating with thiamine. Again, it's an easy way to earn some points and a very quick way to lose some points. Opioids, I'm not going to spend too much time on their pharmacology. Now, with the opiates and the stimulants, and I shudder to go back to the positive and negative reinforcement, but I have to. You have to think about positive and negative reinforcement. Because if I take 3 different opioids with 3 different PK profiles, all right, any opioid that has a fast onset, any opiate with a fast onset, any stimulant with a fast onset, right? Because you have to remember, people are using non-medical prescription drugs, right? So you have to take it. You have to. And benzodiazepine, same thing. Drug with a very fast onset is a high likelihood of positive reinforcement. A drug that has a long half-life on the other side, right, self-tapers and has a lower incidence for negative reinforcement. So the faster you get it in, the higher likelihood of positive reinforcement, right? And you can do the converse on both of these, or the inverse, I'm sorry, rather, right? So if you have a slow onset drug going in, that decreases positive reinforcement, right? And the opposite is true over here. If you have a drug that's gone quickly, you increase negative reinforcement. If you extend it, you decrease negative reinforcement. So 2 different kinds of reinforcement, 2 different onsets and offsets. And they're actually mirror images, right? If you had a drug quick on, quick off, that's bad on both sides. That's positive and negative reinforcement. If you had a drug that's slow on and slow off, that's good in terms of addiction potential because you have less abuse potential, right? There was a hand up over here. That's why pharmaceutical companies keep coming out with more and more opioids that are the same drugs, because they're trying to, with risk mitigation strategies, they're trying to find drugs, medications that have lower abuse potential because they either have an onset that's very slow or an offset that's very slow. Now, quick thing about opiate withdrawal. It's not life-threatening unless there's a medical complication or some other condition that would make it so. It's generally not by itself going to be a medical emergency. And if you've seen Requiem for a Dream, it seems like it would always be a medical emergency, but that's not the case. It's very uncomfortable, but it's not a medical emergency. Stimulants, we've went through those quite a bit. The big thing with stimulants, again, it's not a life-threatening emergency, just like with opioids. And again, if you think about homeostasis, you're putting on a CNS stimulant, your body counteracts with inhibitory neurotransmitters, and a lot of the symptoms, so it's an easy way to kind of remember what it looks like when you're done. You have a lack of dopamine because you peaked your dopamine, and now it's gone, right? Everything has a rebound, right? If you have a burst of activity at dopamine receptors, and then you take the drug away, if you remember the graph I showed you, it's the same thing with receptor occupancy, right? You kind of get a rebound. So there's that short time when you're actually deficient in that receptor that you just, it's like anything. If I have a bunch of sugar coursing through my veins right now, it's like a caffeine high everyone talks about. You get a burst, you study for an hour or 2 hours, and then you have the crash afterwards, right? Same thing with dopamine. When you have that crash, you have a point where your dopaminergic activity is actually low. It's low. So that contributes to some of the low mood, but you also have the CNS inhibitory neurotransmission. So what it looks like is the opposite of what the acute effects look like, right? All these drugs. The withdrawal should look opposite is what the... So if you can remember withdrawal symptoms, you can generally, or acute use, what acute use looks like, you can generally at least, intuitively say, well, what should the withdrawal look like? And with stimulants, it can mean depression, lethargy, drug craving. Benzodiazepines are a medical emergency because they're very, very similar to alcohol, right? They're very similar to alcohol. If you're using high-dose benzos over a period of time, and then you withdraw the CNS depressant, you're in a state of CNS hyperexcitability, and you can have seizures and so on and so forth. The same that you can with alcohol. So it's particularly evident when you have high dose over an extended period of time. So alcohol and benzos, think about this as you're going on in test questions and then APPEs, and then eventually when you get down to in a real life setting. Alcohol or benzodiazepines, you should immediately be thinking, what do I have to do from a medication standpoint? I have to treat, and with both of these conditions, it's usually going to involve some kind of agonist, which we'll get to when we get to treatment. But you're usually going to supplement to block that hyperexcitability, right? You're usually going to treat to block that hyperexcitable CNS state in both of those conditions. In opioids, what you're going to usually do, which we'll get to, it's not a life-threatening condition, but you're going to use agonist treatment just to get them through the discomfort and the agony of being in acute withdrawal, and in long term, you're going to use agonist treatment to prevent negative withdrawal. And then stimulants. Stimulants have pretty much no effective pharmacotherapy that's proven at this point, which we'll get to. The first three categories of alcohol, benzos, and opioids, at least you can use something for. With medication, stimulants, again, I told you during the positive and negative reinforcement slide that people have been looking at methadone, or not methadone, methylphenidate for years because it does occupy receptors, and the thought is that you would decrease negative reinforcement without having the high, but all of those have been, not one trial has really come to pass. Not one trial has been. There have been positive trials, but there's also been negative trials, and it's just that literature's a mess. There's a vaccine for cocaine for stimulants. It has all kinds of medical complications. Basically, stimulant pharmacotherapy at this point in time, in January of 2012, is abysmal. Put it that way. But I will tell you more about that later. There are drug use specific scales. What we'll do before, maybe we'll do we get the cases and such. You want to be able to use something like the CIWA. The CIWA is the Clinical Institute Withdrawal Assessment for Alcohol, and then the COWS is the Clinical Opiate Withdrawal Scale. These are scales that you can apply to someone's symptoms and say, all right, you're in alcohol withdrawal, I know that. How severe is it? And do I need to treat? Well, again, I told you always have to treat, but there are cutoffs at which you don't necessarily have to administer med. But we'll talk about how to interpret those. Like I said, more of in a case-based format, or when we get to the treatment side. But because they're going to become more important when I'm sitting there as a clinician, and I need to know, do you need med now? I know that over the course of the next 3 days you're going to need med. But do you need med all the time? We're going to talk about a couple of different approaches. Do you need med all the time? Probably not. I'm going to make a compelling case, I hope, that more compelling than earlier, that you don't need med all the time. But you do need med when you need med. But we'll get to that. So we'll use the scales for that. So I don't even want to ask you if you have any questions, because I know that you're probably still confused, but let's do it anyway. What do you got? I am going to figure out a way to figure that out. Make sense? Was that redundant? This slide here. Yeah, but ask me the questions now. The other day, everyone started creeping up to the front again, and I had at least 5 people up here, and I thought it was very clear that it was office hours. I want other people to hear these. or see them on discussion board, right? But not in a big line asking the same question.
You haven't used